All right, good afternoon, everyone. In the interest of time, we're going to go ahead and get started. So welcome to the 2025 Industry and Science Showcase. My name is Michelle Tabb, and I'm the Chief Scientific Officer for the Molecular Division of Diasorin. And so it's my pleasure today to introduce this workshop and our wonderful speaker, Dr. Morgan. But before we get there, I just wanted to also give you an overview of the Diasorin molecular systems that are available now, and also those that are coming to the market soon, especially now that we have joined forces with Luminex. We have everything from point-of-care testing molecular coming all the way to the highly multiplexed syndromic panels. And so over here on the left of the slide is our point-of-care device, the Liaison NES. It is a 6-channel instrument, and so stay tuned for more news on that soon. If any of you are attending the ADLM conference coming up in Chicago, I believe we will have it there. Towards the center, moving on to targeted testing, our Liaison MDX system, and then coming soon the Liaison MDX Plus. And then over on the far right, our multiplex syndromic solutions. And so for those of you who have known Luminex since the days of Nanosphere, you see there the Verigene system, and we also, of course, have the MagPix and LX200 systems. But what we're going to talk about today is the LiaisonPlex system. And the LiaisonPlex is our brand new sample-to-answer customizable syndromic testing solution. So this is all-in-one cartridges. It combines all the different steps that those of you who are current Verigene users are experiencing today. It combines them all into an easy-to-use cartridge with easy setup, and still allows you that syndromic testing that you're used to having with all of the targets. But we have one very special feature, which is going to be discussed a lot today by Dr. Morgan, and that is Flex. And so what does that mean? That means if you have a respiratory panel of 19 targets, you don't always have to analyze all of those 19 targets that have been run when the assay was run. You can actually select the targets that you need that are appropriate for that particular patient population, or those that the clinician wants to see. And even when you find that those first selections are negative, you can come back up to the system and analyze more results as requested. So it's a really amazing new system with these amazing new features. And so to round out my introduction, I'd also like to talk about what's available now on the system. So I just mentioned the respiratory panel that's FDA cleared as of last year. And I'm really happy to say that as of last week, we have FDA cleared our third of 3 blood culture panels for the system. So our first was our blood culture yeast, followed by our blood culture gram-negative, and then most recently our gram-positive. So those panels require the use of the traditional clinical micro workflow. You take from a positive blood culture bottle, perform your gram stain, and decide on which panel would be appropriate to use based on that result. And so I think if there's time at the end of Dr. Morgan's talk, she will also describe a bit about those panels. And then in development, we have a gastrointestinal flex panel with a very nice selection of targets for viral, bacterial, and parasite targets that will also have this flexible feature like I just described for respiratory. And we also have a meningitis encephalitis flex panel in development. So that is our menu so far. And just before I turn it over to Dr. Morgan also, our booth is 1201, so please come and visit us. We have 2 posters on Sunday presented by internal teams or working together in collaboration with us. We have our Simplexa Candida auris direct clinical study on Sunday in a presentation, and we also have an analysis of respiratory flex testing and the possible cost savings associated with that from using our system that's going to be presented on Sunday. And so now I'd like to introduce Dr. Margie Morgan. So Dr. Morgan is the medical director of microbiology and a professor in the Department of Pathology and Laboratory Medicine at Cedars-Sinai in Los Angeles, where she's worked for the last 40 years. She obtained her PhD in microbiology and immunology at the University of Oklahoma and did her fellowship in clinical micro at Mayo Clinic. And she's a founding member of the Cedars-Sinai Antimicrobial Stewardship Committee and is involved in hospital epidemiology surveillance, operations, and investigation. She has over 100 abstracts and publications in everything in terms of research interests, including antimicrobial stewardship and advancements in diagnostic technologies. She's also played an active role in teaching, both residents and ID fellows, and she's been awarded 3 Golden Apple Awards for outstanding teaching. She served on many committees over the years at ASM, and she's a past president of the Southern California chapter of ASM. And today she's going to discuss how Cedars-Sinai is optimizing syndromic testing with liaison plex and flex testing, including implementation, clinical use cases, and operational drivers behind the shift towards customizable panels. So without further ado, Dr. Morgan.
Hello, everybody. I hope you all are having a good morning and enjoying your lunch. I have been at Cedars for 40 years, but 10 years prior, I was in Oklahoma City at St. Anthony's Hospital as a medical technologist. And so I kind of have an odd view for a PhD director in microbiology in that I've worked the bench, and I continue to work the bench because I love the bench. You know, that's where you learn everything. That's where you see the problems. That's where you see how you can solve problems. So I do have kind of a different perspective. And the other thing that I have a little bit different perspective on is maybe where I'm coming from. Cedars-Sinai is a huge institution. We say we're 920 beds, but we average about 1,000 these days. And we're a level 1 trauma center and have all sorts of different kinds of patients. And so why do I even talk about this? You probably know what Cedars is all about. But because we are major trauma, major transplant, very low pediatric, we might have a very different need for respiratory testing and different things than you might at your medical center. So it does kind of matter, you know, where you are and what you do. We also have the unique situation that we're the Region 9 Special Pathogens Program. So sometimes we have to reach out and do some fairly crazy things. And Dr. Daisy Contreras is here joining me today here in the back. She's my co-director in microbiology. And we work in the microbiology aspect of special pathogens. If you want some crazy stories and talk about things after this talk, we'll talk about special pathogens. That's where some of the craziness is going. Do you remember we're in cow country, right? Yeah, who knew? LA, major cow country. And so we've been seeing a lot of things going on around the Los Angeles area. Not to digress too much, but let's talk about my Plex adventure. Now, how long have I been on my Plex adventure? Well, it began in 2016, believe it or not, with the Nanosphere Veraging system. So I think I can talk from kind of a maybe different perspective than some people. I've had a lot of experience with the old system and some experience with the new, so I can certainly tell you the progress that has been made. What has the problem been over time? Well, we've had a lot of uncomplicated upper respiratory tract infections over the last 10, 15 years with a lot of visits to physicians. But most of them were viral. But unfortunately, most patients were prescribed antibiotics. And that is one of the reasons why antibiotic resistance has been increasing since 2015. Community-acquired pneumonia still remains a big issue, and viral pathogens are more frequently detected than bacteria in most of our patients, as I'm sure you well know. There's rapid, focused molecular testing for viral pathogens, and they can certainly assist in diagnosis and perhaps lead to less use of antimicrobials. At least that's what we want. So we were left with choices with our testing back in 2016. Our choice number one was let's go with one size fits all. We can have a giant multiplex respiratory panel. It was a fixed panel, could do everything, but boy, it cost a lot of money. Just the panel itself cost a lot of money, and there was a large number of targets on that panel, more maybe than was reasonably needed, and certainly more than the physician intended to order. Our choice number two at the time was, okay, maybe that multiplex panel isn't perfect, but the alternative isn't as either. We might have to use multiple instruments to match physicians' orders for select targets. Perhaps we'd have to do some laboratory-developed tests or send out to reference labs to meet what the physician really wanted if we did a more focused approach. This would result in a lot more complexity with training, doing different kinds of validations and such, so that would not be perfect either and could cost a lot of money. Also at Cedars, we've always tried to have some other considerations. I, being a mother of a child who was critically ill for many years, I'm very aware of what goes on with the patient and the insurance. And so we want to do testing that is sensitive to the laboratory testing costs, particularly for the outreach and outpatient population that might not get very reimbursement for some of the testing that's performed. Insurance plans require increasing patient copays or plans or no pay for certain types of services, such as we've found to be true over the last few years with these multiplex type panels. What about the insurance? Well, the patient versus payer mix has been a big issue. Medicare and Medicaid is becoming more and more prominent, and commercial insurers and a lot of people are having to self-pay. So we need, with a shift toward Medicaid and Medicare, we need to reduce the reimbursement required for laboratory testing and possible, and as I said, possibly with elimination of reimbursement altogether for some of the multiplex panels. We need to be aware of the total picture, how some of these tests could affect the patient and their billing situations and payment, and how it could affect hospital reimbursement for performing these very expensive multiplex tests. So my problem continued back there in 2016. The multiplex respiratory testing was very expensive. We had a very high test volume, and it was going up. We weren't doing 3 a day. We were doing 30, 40 a day. So if we were using a rapid, a huge multiplex panel, that was a lot of money. And boy, our administration noticed that we were spending a lot of money. It is the only test in my 40-year history of Cedars-Sinai that they came and said, you can't do all these tests. This is costing a fortune. The reimbursement is very poor, and can you look for another possibility? And so we needed a new replacement assay. It needed to be less expensive, but still capable of rapidly detecting a large number of pathogens. Well, that's not much. Thanks, administration. What am I going to do? So we needed to also consider labor and efficiency of verification, competency, and ongoing testing using one test platform would have been desirable. We needed clinical and financial information to back up anything that we did, because I can tell you we were under the view of administration, and they wanted us truly to find a less costly option for this testing. So we found the Nanosphere Varigene Respiratory Pathogens Flex Test. I have to admit, at first I had no clue what they were talking about, but we had some conversations with my friend Chris over here. Yes, and we thought it would work for us. It may not work for all of you. It may work for all of you. I have no clue, but we thought it would work for us, and it did work for us. So what it is you have one molecular panel covering the continuum of respiratory testing, as you see listed on this slide. In 2016, those were the targets. They're on the respiratory panel. It was multiplexed, and it included Bordetella pertussis, which at the time in Los Angeles, we were having some issues with Bordetella pertussis and having to send everything out for reference laboratories because it was ordered as a single target test. But they had this broad panel, but it had a twist because you could flex, okay? You could divide it into 5 testing categories, as shown on this slide, and you had the ability to actually customize a panel. Only one category or pairing of targets. It was up to you to create panels which could work best in your particular situation. So the panels that we created, you might say, we were crazy, those won't work for us. That's okay, create your own. That was the beauty of it. Of course, back then, this was prior to COVID. Things were much simpler back in 2016, shall I say. And so we took into account seasonal virus prevalence, primarily when we were making our panels. And we came up with these situations, or these panels. We had 4 separate panels. You can see that one was called the primary seasonal influenza. One was influenza with typing. And one we called random viruses of respiratory tract. And it's an odd name, and we questioned that name even after we made that name, so I agree with you. Okay, but it worked. It worked for us. And then, of course, we had a Bordetella panel. So if you take a look to digest what we created, but knowing that you could have created these or different panels that would work best for you. Why these panels? Well, it was in sync with our historical ordering patterns and our seasonal virus variation in the Los Angeles area. We had collaborative discussions to create these as well. I can tell you, over time, I don't know how it is at your institution, but at Cedars, we have come to the firm conclusion, never make any decisions by yourself. If you talk to people and have collaborative discussions, even if it's a stupid decision, they won't just blame you. You can blame everybody. We together made a stupid decision. So we very, very much believe in collaboration at Cedars. And so we talk to our ID people. We talk to our infection prevention people and the Antimicrobial Stewardship Committee. And they helped us establish these panels as well. During the 2016 season, this is how we evolved our testing. Back then, we were still using an immunoassay for influenza A and B. And so for our patients in ED, the emergency department, urgent care, and some of our clinics, where some people were even cash pay, we offered this option for testing. It was a rapid turnaround time and relatively inexpensive. We also still offered our BioFire multiplex panel. The pediatrics and adult intensivists, those patients that were in intensive care units, wanted a rapid and very broad approach. They argued that this was necessary, so we allowed the testing of a few per day from those sites. But our primary testing became on the Nanosphere Viragene RP flex panels. The adult and pediatric general medicine units, adult intensive care units, when they needed very limited targets, they all started ordering these panels. It was very good in our outreach testing, particularly as time moved forward and the massive multiplex panels were not being reimbursed. And it was also very good targeted testing, which everyone was saying that we should do. And so this gave us a very, very good option for targeted testing. So how did it work? Well, we would, as a user, select the desired panel for each sample on the touch screen, and this would be based on the physician and what he ordered for testing, he or she. The second was select appropriate panel based on the MD order via the touch screen. And then once the test was run, we would receive and report the results from that particular flex panel. And then if the physician decided, all those were negative, maybe it's something a bit more unusual or something I didn't think of, they could call us back and we could open up the other targets on the panel. You're only paying in the laboratory for targets released, and the patient is only paying for those targets that are released. Back then, they had a monthly report that we prepared and sent to the Nanosphere Viragene people, and they transferred it to their system and would charge us if we needed to be for opening up too many panels. But as you're going to see, it really wasn't much of a charge because we had very good use of just the targeted flex panels. This was our acceptance back in 2017, and this was during flu season. So you can see that by far, most of the physicians were ordered directed flu testing for influenza and RSV. They were not asking for every virus to be opened up, very seldom. And so we did make use of this targeted approach. Okay, it all does sometimes, unfortunately, get back to, did we please our administration? Did we start out doing and creating a plan that met their criteria of spending less money with better patient reimbursement? Well, if you look at the different scenarios on this slide, 1, 2, and 3, you can see what the cost of one would have been, and that would be the total, everyone getting a multiplex panel. Our laboratory costs, just the cost of supplies, would have been around $130,000. Scenario 2 was with our algorithm of doing the EIA, the multiplex panel, plus the flex panel. We were spending about $85,000. If we could have switched over entirely to using flex panels, we would have been at $65,000. But even in scenario 2 is what we had done, and we accomplished, mission accomplished, yay. Administration was speaking to me again. They were not going to do something horrible to me. So it was focused testing for most requests and multi-target testing for our ICU patients, and we did show a considerable savings. But at the same time, we were offering targeted, good testing for our patients. So it was a win-win situation. So how did this flexible testing assist? Well, we were ability to adapt to physician ordering patterns. We had this focused testing and release extra targets if needed. We had created the panels with 5 targets with 1 billing CPT code, so our patients were not calling us crying about the lack of reimbursement for the multiplex panel. I think one of the most upsetting conversations I'd ever had in my life was a woman who called me who had twins that were taken to a pediatrician's office, and they had, before we started the flex testing, we did the multiplex testing for them, and neither panel was paid for or reimbursed by insurance. And it was just a horrible, horrible situation. And that really set in my mind that we do truly, you need to think about the patient and the reimbursement. So moving to these flex panels, having the targeted usage and the good billing practices, it was a win-win for our outpatient and outreach patient population. It also eliminated send-out tests, which has always been a motivation. We would rather do all of our testing in-house. The turnaround time is better. And we had decreased laboratory costs, met our financial goal, and quieted administration, as I said. So that was my history with the older Flex panel from Verigene through the Luminex. Now we're into the Liaison Plex system. So let me talk about moving from the old to the new. So this is the Liaison Plex, which was introduced to you earlier with Michelle, and you can see that it is a smaller instrument than we're used to, and I'll show the comparison in a moment. It really is assists greatly with diagnostic stewardship. Fiscal responsibility with the Flex panel is still available, and I'm going to talk a lot about the operational efficiency that has been so massively improved with this system. So let's compare the systems. One could say there's really no comparison. Back in 2016, before some of you may have even worked in laboratories, we went with the flow. Nothing was too easy to do back then. Everything kind of had multiple pieces you had to chase down and multiple orders and take a while to set up. And we just kind of, that was just part of the function of the laboratory. But as time to move on, we needed more efficiency. And you do have this new and good efficiency with the Liaison Plex system. If you're not familiar with the old, it's over on the left-hand side. You can see how big the system is compared to the Plex system, which is about a third the size, shall we say, so it takes up much less bench space. The chemistry is the same, but the consumables, that's a big, big difference. The older system, if you have used it, you know that there was something in the freezer, something in the refrigerator, and you had to go track down everything every time you wanted to run a panel. That is not true with the Plex. Everything is in room temperature storage, very convenient, one cartridge. The manual setup and transfer to the reader had to be done with the Nanosphere Verigene system. Once the test was finished, you had to remove it and then put it into the reader. That is no longer with the Plex. It is automatically read when the cartridge is placed in the instrument. And the LIS capabilities have also been improved. So I think you can easily see that it's a much easier system to use. I can tell you that our molecular people, they are having a much easier time of it since we switched to the Plex. These are this panel on the new Plex, which was released in 2024-2025. You can see the viruses and the bacteria. If you look at the ones in bold, you can see the new targets that have been added to the panels. So some of the human coronaviruses, of course, SARS-CoV-2, Mycoplasma pneumonia was a big addition for us, and that has been a very, very helpful addition preventing send-out tests. So how do we create our new Flex panels? These are our new 6 Flex panels. Once again, you may think we're crazy. Those panels wouldn't work for me. Why did you create these panels? Well, you don't have to create these panels. You can create your own. But these are the 6 that we created. As I had said earlier, a lot of people think I'm kidding, but we are in cow country in Southern California. There's a lot of dairy farms just north of us, and we were mandated by the Department of California, Public Health Department, to subtype all our influenza A's during last season. Even through the summer, we are continuing to subtype all. And so we had that subtyping module to help us with our subtyping of all of our influenza A's. We also found that the Mycoplasma pneumonia target was extremely beneficial. And we no longer have to send single target mycoplasma pneumonia tests out to reference laboratory. The other thing that has changed with the Flex system is how it works with your credits. The Flex software enables users to pay based on the targets you process and result. So you purchase 100 liaison credits and then consume these credits, and you do not use a credit unless you release more than 7 targets. And then over time, if you use all your credits, you make arrangements with the DSORN people to buy more credits. So it's a little bit easier system and does not require monthly work to get your credits billed. This is how the system works. It's powered by innovative and proprietary technologies. You can see the cartridge. Those of you who use the old system can see it's very different than the old system. And it is nanogrid technology. It gives you a very good, sensitive and result. And it is, as I said, stored in room temperature. And it incorporates all of your extraction, amplification, hybridization, and microarray resulting in the same cartridge. Oh, is it easy to do compared to the other one? Oh, yes. I can't even tell you how many hundreds of the nanosphere Veregene I've done over time between the blood cultures and the respiratory testing. This is so much easier. You just use a pre-measured a pipette that has pre-measurement on it and put it into an open little door, close the door, barcode it in, and then it goes into the system. And it is just so much easier than the prior system. And it uses, of course, a nasopharyngeal swab collected in universal transport media, a small volume, 300 microliters. So if you need to do additional testing or send out for other reasons, there should be specimen left in your universal transport media tube. Of course, you collect with the flox swab. And as I said, it's all the extraction and everything goes in that very nice cartridge. And I love that it's stored at room temperature. That is so much easier than all of the freezer and refrigerator storage. So I have some questions that I thought you were going to ask me, so I'm going to ask my own questions to myself, okay? So if MDs have a choice between a targeted flu, RSV, COVID test during the winter viral season or a very broad multiplex respiratory panel that covers everything, what are they going to order? Well, I think what I would say is in my hospital, as I said, the intensivists and pediatrics tended toward wanting still that broad multiplex panel. And we never said no to them because they have some very critical situations and I'm not going to get in an argument with an intensivist. How about just our general medicine patient population though and people in the ED that are going to be admitted to the hospital? Well, what we did is we didn't leave it up to the physician to make the decision. I don't know about you, but my physicians are kind of like herding cats. And we have about 2,800 physicians at Cedars. Now, some are on faculty, but most are not. And so we can't necessarily just tell them what to do or stop orders on them. So we had to go through education and discussion with physician groups, and we encouraged this focused testing population, also telling to them how it could benefit their patients and payment. You know, patients do call physicians complaining about what ref lab they used and how much stuff costs. We hear about that. So if you do have reasonable billing and payment, it's just better for everyone. It was our, also we rearranged the ordering menu on our EIS system. We put it at the top and we put the multiplex down here somewhere, and I'm not sure you could even find it if you looked really hard. Maybe that's evil, but sometimes you have to do the obvious. They're going to order the first targeted test that they see, okay? No one argued with that. The physician group said that makes perfect sense because they tend to just pick viral panel. I just want viral. If it says influenza A, B viral panel and it's at the top, they'll pick that one. That's what they need. We had soft stops on the broad multiplex panels for non-ICU patients. We didn't stop it. We just put in a comment saying we would advise you not to use this and prefer a targeted panel. And we had totally hard stops, did not perform any of the massive multiplex panels on any of our outpatient outreach locations because we were very concerned what the billing would do, and they would have to pay cash for such services. More questions. Okay. Is it unethical to test all of these targets and only release a few? Okay, so all the data's in there to be released if you need so. But if you are testing what the what the physician orders, and you're releasing what the physician orders, we do not feel that there's anything wrong with that. And the other results are there if they were to call back and want the tests released. Has our billing department had any issues handling reflex testing or the CPT coding involved in such testing and with the release of extra panels and such? No, they have not complained to us at all, and things have gone very smoothly. So what's next? Well, I'm very happy that we can move all of our testing from the old Verigene system into the liaison plex. And I'm very happy that the gram-positive, gram-negative, and yeast panels are now available for testing for direct positive blood cultures. We will make best use in my facility of the gram-positive and of the yeast. And I think it's just being released. Take a look. I think it could be very, very helpful for your testing. I think the pictures show better than this. This is your gram-positive bacteria that are on the new panel with the addition of bacillus and the MEC-C markers. So that will be available to you very, very soon. This is the gram-negative panel with the addition of many organisms and resistant markers. And then I'm very happy and pleased to see this yeast panel. We've had issues, some with direct testing on MALDI and such for yeast. I think this panel could be very, very helpful. I don't know about your medical centers, but we're seeing far more yeast than we used to and unusual species. And so I think this could be a very, very useful panel. And with that, I end. I say thank you. Thank you for attending. And you can always go by the booth if you have more questions and such. And I'm happy to take any questions that you might have. Thank you very much for listening. Silence. Silence is golden. I appreciate silence. Oh no, we have non-silence. Okay, I won't accuse you of anything. Okay, go ahead. I can barely hear you. There's so much background noise. That's a very good question. He's asking what we would find when we would open a panel. Would it all of a sudden, blah, blah, have the diagnosis? I do not have the actual statistics, and I apologize for not doing so. I think on occasion, rare occasion, we would find a pathogen. But you know, for the most part, I think everything would be negative. Particularly if you're dead winter, the primary virus circulating is influenza A, RSV, and they're asking us for open up a panel for Bordetella or something. We're not going to find much. But that's not our decision to make. It is the clinician's decision. So. We always will open if asked. We will never deny opening the panel. Do they call back all that much for an opened panel? No, only about far less than 10% of the time. That's why I think this system has worked so well for us. The gram-positive blood culture has worked very well for us. And as I said, we're hoping that the yeast will work well for us. Okay. Other questions? Yes, ma'am. We ask which pathogens that they're looking for. There's certainly no need to open up a Bordetella pertussis panel if there's no thought whatsoever. Normally, they want the random virus type, the one with the parainfluenzas, human metapneumo, that panel opened up in addition to the influenzas. Yes, because if we open both of those, we will have more than 7 targets exposed. I'm going to be here for in the meeting if you want to ask any other questions. I really thank you for coming, and I hope you have a wonderful stay in Los Angeles. Thank you.